Hi, this is Pratima and you are watching Planet Physiology. In Introduction to Renal System, we have already studied the parts of nephron in detail. Today we shall study role of each of these parts in urine formation. Since this is quite a big topic, today we shall concentrate only on basic terminologies and role of proximal convoluted tubule in urine formation. The first step in urine formation is glomerular filtration. We have already studied this step in detail. This filtration process is non-specific, where all the components of the plasma except plasma proteins get filtered. The second stage of urine formation is tubular processing of the filtrate. As this filtrate passes through the renal tubules, tubules reabsorb the important substances back into the circulation. This process where substances are transported from filtrate into the blood is called reabsorption. At the same time, metabolic wastes which were not filtered sufficiently are transported from blood into the filtrate. This process is called as secretion. All the parts of the renal tubules are engaged in the process of reabsorption and secretion. Finally, at the end of medullary collecting ducts, filtrate gets converted into urine, which is then transported to the bladder for excretion. Thus, tubular processing of the filtrate decides the final composition and volume of the urine formed. Before proceeding further, let us understand basic terminologies related to tubular reabsorption and secretion. Reabsorption is two-step process. In the first step, substances are transported from lumen of the tubules into the interstitium. If the substances are transported from filtrate into the interstitium via epithelial cells, the process is known as transcellular reabsorption. This can be active or passive transport. If the substances move from filtrate into the lateral intercellular spaces via tight junctions, it is called as paracellular reabsorption. Paracellular reabsorption is usually passive process. In the second step, water and solutes are transported from interstitial fluid into the peritubular capillaries via bulk flow. Tubular secretion occurs in a reverse direction, where substances are transported from peritubular capillaries to the interstitium and then into the filtrate. If you remember, GFR is 180 liters per day. So out of this 180 liters, 178.5 liters is absorbed in a day by the renal tubules. This process is highly selective and allows conservation of all the important substances and excretion of waste products. Next term you should know is tubular load or filtered load of a substance. It is the amount of solute filtered by the glomerular membrane per unit time. It is calculated by multiplying glomerular filtration rate and plasma concentration of the substance. Tubular load is expressed in milligrams per minute. Another term is transport maximum. It is the maximum rate by which the substance is reabsorbed or secreted by the renal tubule. Whenever tubular load of the substance is greater than that of its transport maximum, substance appears in the urine. Transport maximum is due to saturation kinetics of the carrier proteins. Some of the actively transported solutes like sodium and potassium do not exhibit transport maximum. Instead, they show gradient time transport. The last term you should know is renal threshold. It is the plasma level of a solute above which the solute first appears in the urine. If the solute is normally present in the urine, then renal threshold is the plasma level above which the solute exceeds its normal concentration in the urine. Okay, with this basic understanding, let us start with the role of proximal convoluted tubule in urine formation. Initial part of proximal convoluted tubule is highly coiled and hence called as pars convoluta, while the later part is relatively straight and hence termed as pars recta. There are some functional differences in the types of channels present in these two parts and hence their functions. In proximal convoluted tubule, epithelial cells possess extensive foldings and microvilli on their luminal side and hence it is known as brush border. This increases surface area for reabsorption by 20 times. Brush border is loaded with various carrier proteins. Basolateral surface also has multiple infoldings and the cells possess many mitochondria indicating their higher metabolic activities. Adjacent cells are bound to each other by tight junctions at their luminal border. Because of these histological features, proximal convoluted tubule is the major site for reabsorption. It reabsorbs solutes like sodium, potassium, chloride and bicarbonates, nutrients like glucose and amino acid, and of course water. Driving force for reabsorption in proximal tubule is sodium because it has many sodium link cotransporters. Proximal tubule also secretes hydrogen ions, organic acids and bases. So let us study in detail how these substances are handled by PCT. This is the diagrammatic representation showing longitudinal section of proximal convoluted tubule. This is the lumen of PCT. These are the epithelial cells lining PCT. This is the luminal surface of the cell representing brush border. This is basolateral surface which is in contact with the interstitial fluid. Here is lateral intercellular space containing interstitial fluid. And this is the peritubular capillary. So let us start with the sodium reabsorption. Basolateral border of epithelial cells has many sodium-potassium pumps. They constantly pump 3 sodium into the interstitium and 2 potassium into the cell. As a result, sodium gradient from tubular lumen to epithelial cells is generated. Being electrogenic pump, it also creates negativity of about -70 millivolts in the epithelial cells. This electrochemical gradient facilitates sodium influx. So as sodium ions enter the epithelial cells, they also carry other substances like glucose or amino acids with them by symport or hydrogen ions by antiport. Thus, proximal tubules reabsorb sodium by active transport. Sodium reabsorption is coupled with movement of other solutes like glucose, amino acids, hydrogens, potassium, etc. PCT reabsorbs about 65% of the filtered load of sodium and it is obligatory reabsorption which is not dependent on hormones. Next solute we shall study is glucose. Glucose is co-transported with sodium from luminal border with the help of carrier protein SGLT2. Once glucose enters the cell, from basolateral surface, it diffuses into the interstitial fluid by facilitated diffusion with the help of GLUT2 transporters. Under normal conditions, PCT reabsorbs 100% of the filtered load of glucose and hence glucose is not excreted in urine. Drugs like florizin causes competitive inhibition of SGLT2 transporters and thereby reduces glucose reabsorption from PCT, leading to glucosuria. So in short, normally PCT reabsorbs 100% of filtered load of glucose. It is active process coupled with sodium. Glucose reabsorption exhibits transport maximum as carrier shows saturation kinetics. Average value of transport maximum for glucose is 375 mg per minute in males. When filtered load of glucose exceeds transport maximum or if the carrier proteins are inhibited, glucose appears in urine. We shall study details of TMG in a separate video. Similar to glucose, PCT reabsorbs 100% of filtered amino acids. They are also co-transported with sodium from luminal border and by diffusion from basolateral border. Now coming to bicarbonate reabsorption, it is coupled with secretion of hydrogen ions. Pars convoluta of PCT possesses sodium-hydrogen countertransporters which reabsorb sodium in exchange for hydrogen ions. These hydrogen ions combine with the filtered bicarbonates to form carbonic acid in the lumen of PCT. Carbonic acid being a weak acid, it splits into carbon dioxide and water, and both these products diffuse into the epithelial cells. Within the epithelial cells, carbon dioxide combines with water to form carbonic acid. Presence of enzyme carbonic anhydrase facilitates this reaction in both lumen as well as in the epithelial cells. Now, this carbonic acid dissociates into hydrogen ions and bicarbonate ions. Hydrogen ions are again secreted back into the lumen to reabsorb new bicarbonate ions. Now, these newly formed bicarbonate ions are transported into the interstitium from the basolateral surface. Some are co-transported with sodium and some are exchanged with chloride. Thus, reabsorbed bicarbonates are not the same as that of filtered bicarbonates. That is, they are indirectly absorbed. Reabsorption of bicarbonates is active process and is coupled with secretion of hydrogen ions. Carbonic anhydrase facilitates reabsorption of bicarbonates. Normally, PCT reabsorbs about 90% of the filtered bicarbonates, but it can vary depending upon the need of the body for acid-base regulation. Carbonic anhydrase inhibitors like acetazolamide decrease reabsorption of bicarbonates as well as sodium and cause osmotic diuresis. Another important anion reabsorbed from PCT is chloride. Chlorides are mainly reabsorbed passively due to their electrochemical gradient. In initial segment of PCT, sodium preferentially carries glucose, amino acids and bicarbonates. Water follows by osmosis. As a result, chloride concentration in the later half of the PCT is higher. This facilitates their diffusion mainly by paracellular pathway. Even though epithelial cells possess tight junctions, they are leaky. Some chloride ions are also reabsorbed with the help of sodium chloride cotransporters into the cell and then via chloride channels in the basolateral surface to the interstitial fluid. About 65% of the chloride ions are reabsorbed by PCT. Now coming to the water reabsorption, PCT reabsorbs 65% of the filtered load of water by the process of osmosis. Osmosis is mainly driven by reabsorption of sodium and accompanying solutes. Apical as well as basolateral surfaces of epithelial cells lining the PCT has aquaporin 1 water channels. They allow rapid movement of water along the osmotic gradient. This water reabsorption is obligatory. That is, even in absence of any hormonal influence, PCT reabsorbs 65% of the filtered water load. Since solutes and water are reabsorbed in same proportion, that is 65%, osmolarity of the filtrate remains same as that of plasma, which is 300 milliosmoles per liter. As water moves by paracellular route, it also drags many other solutes like potassium, chloride, urea, magnesium, calcium along with it. This movement of solutes with water through paracellular route is known as solvent drag. Amount of urea reabsorbed by PCT is about 30 to 50%, and because of its smaller size, along with the solvent drag, urea also is transported into the interstitial fluid. Now let us see the substances secreted by PCT. First is hydrogen ions. They are secreted by counter-transport mechanism coupled with sodium, as we already studied earlier. Hydrogen secretion is mainly related with bicarbonate reabsorption. But in case of acidosis, PCT can secrete excess of hydrogen ions against the gradient of 4 to 10 folds. PCT also secretes bile salts, oxalic acids, uric acid, catecholamines and steroids. Drugs like indole acetic acid, penicillin and salicylic acids are also secreted from PCT. Chemicals like para-aminohippuric acid, phenol red, iodinated dyes and toxins are also actively secreted by PCT. Thus, organic wastes which are not filtered adequately are secreted by proximal convoluted tubule for their effective removal from the body fluids, and most of them are secreted by active transport process. This graph summarizes the various solutes processed by proximal tubule over its length. Ratio of concentration of solute in tubular fluid and the plasma is represented on y-axis. The ratio of 1 indicates equal reabsorption of solute and water, as indicated by this red dotted line. PCT reabsorbs equal quantity of sodium and water, and hence its ratio is 1, and the filtrate is isoosmolar throughout the length of PCT. If the solute is reabsorbed, its concentration falls in the filtrate as for glucose, amino acids and bicarbonates. If the solutes are reabsorbed in lesser quantity, their concentration in the filtrate increases, as indicated here for chlorides, urea and creatinine. Now coming to the clinical aspects related with proximal convoluted tubule processing of the filtrate, the Fanconi syndrome. It is a syndrome of inadequate reabsorption in proximal convoluted tubule where ATP levels in PCT is reduced. It can be acquired due to toxins like heavy metals, like lead poisoning, or due to adverse drug reactions. It may be congenital disease due to specific mutations of the gene HNF4A in humans. Normally, this gene is specifically expressed in proximal convoluted tubule. There are various forms of Fanconi syndrome. Out of this, two forms, the Dent's disease and the Lewis syndrome, are X-linked diseases. Now, due to reduced ATP, active reabsorption as well as secretion processes of proximal convoluted tubules are affected, leading to decrease in sodium reabsorption from PCT. As a result, there is generalized reduction in all the secondary active transport mechanisms, which results into metabolic acidosis, glycosuria, and amino acid urea. Due to presence of these osmotically active particles in the filtrate, patient suffers from polyuria, polydipsia, and dehydration. Phosphate reabsorption is also reduced, leading to phosphaturia, which causes rickets in children and osteomalacia in adults, because phosphate is important component for bone formation. So as we have come to the end of the topic, let us quickly summarize the important points about role of PCT in urine formation. PCT is the most important segment to recover the essential components from the filtrate. It reabsorbs about 65% of sodium, potassium and water. Sodium and water reabsorption is obligatory. PCT recovers about 90% of the bicarbonates. It reabsorbs 100% of the glucose and amino acids and prevents their loss in urine. Potassium, magnesium, calcium, chloride and urea are also reabsorbed by solvent drag mechanism. PCT secretes various ions and organic contents in the body as well as metabolic end products, which includes hydrogen ions, phosphates, ammonium ion, bile salts, oxalates, uric acid, catecholamines, drugs like penicillins and para-aminohippuric acid. So here we finish with the topic processing of filtrate by proximal convoluted tubule. In the next part, we shall study role of remaining parts of the tubules in urine formation. Thank you for watching and see you in the next video. If you enjoy my presentations, press the like button and share it with your friends. For more such videos, subscribe my channel and click the bell icon. Thank you for watching and see you in the next video.